chest x-ray is a very low dose, about 0.1 millisieverts. A diagnostic quality chest CT is about 2 years worth of background radiation exposure, 7 millisieverts. And the low dose chest CTs that were used in this screening trial have about a radiation dose of about 1.5 millisieverts, about half of what you would get in an average year of exposure. And the additional risk of dying from a future cancer from the low dose chest CT is about 1 in 100,000. That's added to the average risk of all people of having a 1 in 5 lifetime risk of lung cancer. So it's a very small risk. And I would just say that you don't use imaging unless you need it. In case you haven't seen, this is what a CAT scanner appears like. It's got a table for the patient and then passes through the donut of the machine, which contains an X-ray tube, which passes around the patient in this helical trajectory. All CAT scanners today are of the helical design. And in the late 90s, they had a technical advancement in CT scanners where we have this so-called multiple slice or multi-slice capability, where we can get multiple slices or photographs of the body part of interest in a shorter amount of time. And so we can do scans of the chest within seconds. In terms of the National Lung Screening Trial, or NLST, it was a collaborative effort between Akron and the National Cancer Institute and derived from 2 arms listed here. An interesting fact, this is the largest and most expensive randomized clinical trial of a single screening test in the history of United States medicine. Overall, the cost was about $250 million. In terms of the study design, this was a prospective study with a randomized controlled trial design. And so high-risk subjects were randomized to either getting a low-dose chest CT or chest x-ray for 3 consecutive years, and then were followed. In terms of who could participate, these were older patients, 55 to 74 years of age, who were heavy smokers, either current or former smokers, who didn't have any prior history of lung cancer or other cancers. And the primary question to be answered by this trial is, does low-dose chest CT screening reduce the loss of life from lung cancer by 20% compared to chest x-ray? There were also some secondary questions. How does CAT scan compare to chest x-ray in terms of saving lives overall? The incidence of lung cancer, also in terms of lung cancer stage distribution, that is, how many early and advanced lung cancers are distributed. Medical resource utilization, how does screening affect quality of life and psychological impact, and also cost effectiveness. From a radiologist point of view, when I had to interpret the CAT scans, this is how I interpreted them, as positive or negative. Positive basically means you have a focal abnormality or nodule in the lung bigger than or equal to 4 millimeters, or other findings that are suspicious for lung cancer. Otherwise, the scans were read as negative. And this is just to show that in the trial, there were 33 sites in the United States that participated, one of which was Penn. From 10,000 of the participants in the subject, we not only did imaging, but also obtained some biospecimens, blood, urine sample, and sputum, that were stored for future laboratory analyses. And also for those subjects who turned out to have lung cancer, some of those tissues were also collected as well for future research. This is just to show you the accrual was fairly rapid over about a year and a half, from 2002 to 2004. 53,000 approximately patients or participants were recruited, half getting CT and half getting chest x-ray. The purpose of this slide is just to show you that in the right-hand column, this is the general population in the United States, and the middle column is that in the study, just to show you that the baseline characteristics of the participants were quite similar to those in the general population. On average, they were slightly younger, they were slightly more educated, and also less likely to be current smokers. The purpose of this slide is just to show you that participants who did participate in the study complied with the screening regimen, greater than 90% of compliance, which is very good for that study. And this is to show what the chance of having a positive CT screen would be. On average is about 24%. So 1 out of every 4 patients who were in the CT arm had a positive screening test, whereas only about 7% of those who had a chest x-ray had a positive screening test. And overall, over all 3 screens, participants had about a 40% chance of having a positive screen in the CT arm compared to 16% in the chest x-ray group. And interestingly, looking for incidental abnormalities that are not related to lung cancer, we picked up about 8% of important abnormalities not related to lung cancer in the CT group compared to 2% in the chest X-ray group. This slide is just to show you what the significance of a positive CT screen is. And you can see by the bottom row here, where the circles are, that most of the abnormalities, 96% of those who had a positive screen were actually not due to lung cancer. And the same thing applies in the chest X-ray group. And so this is has some room for improvement in terms of coming up with a specific diagnosis of lung cancer on a positive screening test. I thought I'd show you some examples. So just to orient you, this is a CAT scan of a participant. The bottom of the screen is the back. The top of the screen is the front of the person. This is the right side, and that's the left side. The grayish areas in the middle of the chest are the lungs. And I hope you can appreciate this white spot at the bottom of the right lung. That's a nodule, and this turned out to be a lung cancer in this smoker. And so this screening test actually helped this particular person since this was detected early on. On the left here, we have another patient who has multiple nodules in the lung, seen by these white spots in the left lung. And it's hard to tell just from that first scan whether these are due to lung cancer or due to an infection. If you wait a year, you can see that they all disappeared. And so that proves that these were not due to cancer, but in fact due to an other cause, in this case infection. Here's another patient who comes in, a smoker, who has a nodule in the right lung. A year later, you can see that it hasn't changed, and over other scans that occurred, this never grew, and this turned out to be a benign nodule. And so this was a positive screen, but not due to a lung cancer. Here's a participant who came in, got scanned. Here's the first scan on the left. You can see a large nodule in the right lung. A year later, it actually grew, and so this was removed. It turned out not to be due to lung cancer, but due to a benign etiology, benign cause. And then on the left-hand side here, you can see this tiny little spot right next to the liver there that's above it. And a year later, you can see that it actually grew a little bit. And so when nodules grow, you tend to think that it's more likely lung cancer. This actually turned out not to be due to lung cancer. This was a benign lesion as well. And one more example. Here we have nodule on the left lung that a year later grew slightly, but then never changed after that, and this also turned out to be a benign nodule. In terms of the results, in terms of comparing the incidence of lung cancer in the CT and chest X-ray groups, more cancers were detected in the CT group than in the chest X-ray group. The incidence of detecting lung cancers were similar across all 3 years of screening, and in addition, 367 cancers were also detected in the CT group after the screening period was completed. And this implies that even if you have a negative screening CT test, that doesn't mean that you may not have a future lung cancer. In terms of the outcomes, this is the key slide. 87 lives were saved by CT screening compared to the chest X-ray group, and this equates to a 20% reduction in loss of life due to lung cancer. The number of people you need to screen with CT to save one life from lung cancer is 320, and that definitely needs some improvement, and I'm going to talk about that towards the end. In terms of all causes of outcome, loss of life in general was decreased by almost 7% in the CT group compared to the chest X-ray group, and this was predominantly due to the effects of lung cancer detection early on. Adverse events related to the screening procedure were very few, about 1% to 2% at most. In terms of having a complication after a procedure, it was most common in those who truly had lung cancer, but was still fairly infrequent. And in terms of loss of life, within a 2-month period after having an invasive diagnostic procedure prompted by the screening test, it was very few in number, although 6 patients who didn't have lung cancer were harmed by the screening procedure. In terms of what type of lung cancer is influenced by screening, it turns out that there's a type of lung cancer which comprises the majority of lung cancers called non-small cell lung cancer. That was the one that was most favorably affected by CT screening, whereas a minority of lung cancers called small cell lung cancer was generally not favorably influenced by the screening technique. And of the lung cancers that were detected by CT, the majority, 70%, were of early stage, compared to about 55% in the chest X-ray group. And of the different types of lung cancer you can get, the most commonly encountered one was adenocarcinoma. Now, as I mentioned, specimens were collected from about 10,000 participants during the course of the trial, and these are stored in a central location in the United States. And this is very exciting because these tissue specimens will now be able to be used for future research to try and identify laboratory-based tests to figure out who is truly at high risk for lung cancer, which nodules are benign and malignant in conjunction with the imaging, and also which lung cancers are truly aggressive compared to those that may be more indolent. And this is just meant to show you that we were able to obtain very high compliance in terms of getting the specimens from the participants of the study. And this slide is just meant to show you that we also have specimens from the actual lung cancers that were resected that are available to researchers from around the world to do future research. There are a lot of questions that remain and analyses that remain to be performed. So these are some of them. What are the costs of screening, whether it's direct or indirect? What is the cost effectiveness of screening? That's very important because it has to be within a certain range in order to be practical as a screening test. What are the effects on the quality of life? Does this affect smoking behavior? How does this affect resource utilization in the United States? And then bigger questions. What will the policy recommendations be to implement CT screening in a standardized fashion? That's very important because we need to know, when do you start screening? What age? How often do you get screened? How many scans should you have? How do we integrate this with other preventative strategies such as smoking cessation, diagnosis and therapeutic algorithms in a standardized approach? How do you take these results and apply it to other populations, such as younger patients, or to people who don't smoke as much, or people with other risk factors not related to smoking? And also, this study was performed mostly by centers with expertise in diagnosis and treatment of lung cancer. Would these results also apply to the community setting as well? Also, who's going to pay for all these scans? Will be individual people? Will be the insurance company? Will be the tobacco industry, or a combination of these things? And how can we decrease the number of false positive CT screening tests? How can you truly identify those who are truly at high risk? And that's where these biospecimens and future research will come into play to answer that question. So the bottom line is that for the first time, it's been shown that CT screening saves lives from lung cancer. It does have a limitation of a high false positive rate. Other analyses are ongoing. Other questions about CT screening in general need to be answered before this can be implemented on a wide scale. And I just want to emphasize that smoking prevention and cessation are still critical to reduce lung cancer incidence and to save lives. And I would just say also, it's never too late to quit. There are many acknowledgments. I'm just one of many people who are involved in this study. Here are some of them: National Lung Screening Trial Executive Committee and the National Cancer Institute, many radiologists, of which I'm one, many physicists, many committee and members, patient advocates, study participants without whom it wouldn't have been possible to even perform this trial, and others. And so I'd like to thank you for your attention and be happy to answer your questions. Thanks.
If you can go to the microphone, please.
Since it seems like it's probably a high cost in order to do just screening of everyone, are you thinking of reducing the set of people who get screened by picking people who've seen their doctor because of something that might be some sort of chest infection, but they don't have any other blood work symptoms or raised whatever that might indicate it maybe not infection, but might be something else? Or annual blood work screening, like there's PSA's test, maybe something that says you might be a candidate for being screened for lung cancer because we see some marker in here. Have you merged this idea with any other sort of pre-screening that might give you a much stronger positive sample?
Yeah, you're exactly on the right track. That's where the biospecimen bank is going to play a huge role, because you want to identify those who are truly at high risk and who, out of that population of, say, smokers, for example, should get CT screening because of the cost. Exactly. And also, clinical assessment in a standard fashion will be very important to make sure the person doesn't have an infection or other, other disease process that may account for the presence of lung nodules. So you're exactly right.
I'm biased, broadening that not to focus so much on smokers. I'm a never smoker. There's a lot of never smokers out there who get this. And because we have no risk factors in our history, no radon, no family history, no smoking, no exposure to silica, etc., you go into the doctor, you say, I got a little something, don't know what this noise is. They say, no chance you have lung cancer. Let's just assume it'll go away, or let's just watch it for a long time. So if you can do something that becomes more routine, somebody presents with mild symptoms and they're never smoking, you get some sort of cheap pre-screen that says, let's send you to the CT. That might have made a difference from me being like stage 1 or 2 upon diagnosis versus stage 4.
Right, I agree with you. That's where the laboratory analyses will come into play from genetics or molecular analyses. And clinical assessment still is important for any person who comes in with an abnormality, basically.
I have to echo that. I think ultimately, and I realize many of you out there are never smokers or what we call minimal remote smokers. And the data from this screening trial would not automatically apply to you folks. I believe it was 30 pack years was the minimum.
Heavy smokers.
So
right.
By definition, when we say pack year, we mean a pack per day per year. So if you smoked a pack and a half a day for 20 years, that's 30 pack years. But many of you never smoked, or you chipped cigarettes perhaps in college, but never really ever bought a pack of cigarettes. So it's a much tougher piece of the puzzle. And as Drew has alluded, it's going to take another approach, I think, to really figure out who in the much larger, fortunately, much larger never smoking or minimal past smoking population is truly at risk. And that's going to take some new blood studies, specifically looking at genetic profiles that may perhaps predispose folks to cancer. It may not just be lung cancer, but certainly lung cancer is our interest. We're not there yet. Obviously, that's a major area of investigation. Some of the advocates you heard from earlier, and another one of the advocates you'll hear from the Lung Cancer Partnership, are heavily involved in trying to spur that sort of research on. There's also some interesting work, and perhaps this can come up later. I don't think either Dr. Torigian or I are necessarily qualified to talk about this, but looking at the components of our exhaled breath, actually trying to determine if there's some what they call aromatic agents that may actually, that there may be certain chemical profiles that could be identified that may enable us to figure out who is at risk. So a lot of interesting research coming up, still in the embryonic form. I want to encourage other questions. I see somebody at the microphone, please.
Hi.
Hi.
My name is Heather, and I wanted to just comment on what you had said about how it seems like everything is so focused on the smoking aspect. I became a lung cancer survivor almost a year ago at the age of 24 years old, and I had smoked, but the lung cancer that I had was no way associated with smoking. And even for people my age, when I talk about it, they always associate it with smoking. I must have gotten it from smoking. So I think, a lot of the research even contributes to a lot of the stigma about it.
The reason I think that they did this trial with smokers, heavy smokers, is that if this study didn't work in that group, it would never work in a group without smoking. I think that's and despite that, they still needed 50,000 participants to get statistically significant results. So you can see it's not that simple, but I agree with you. Also, just to answer one other thing, they're trying to take these results, different groups, and trying to model it to apply to other populations, including those who don't smoke, but it's not always that simple to do these analyses.
I think you underscore another issue that's certainly not a sidebar to it, the stigma that's attached. it's very tough. I mean, it's bad enough to have cancer or be a family member of someone with cancer, but to have others look upon you askance as if you're to blame for it is just unbelievable. And to actually have that further applied to you when you never even had the risk factor for it. And I think it's crucial that we move beyond the stigma, not just individually, but as a society. Dr. Rangan and others have shown slides about the dollar spent per diagnosis or even death from cancer, and lung cancer, unfortunately, is way below other cancers. So it's really imperative that our state and our country focus more attention on this disease. Yes?
Hi, my name is Lainey Strom, and I'm just 4 weeks out of lung cancer surgery. Interestingly, I fell down the stairs 3 years ago, and in the process, and I broke my neck, and I had a CAT scan, and that's when they found that I had lung cancer.
Incidentally, yeah.
Yeah, and so they followed it, and then it grew, and then it was taken out. But what I'm curious about, because I've never smoked, of course, but I grew up in a family where my parents were very heavy smokers. And I was just wondering if there's been any studies about people who have never smoked and developed lung cancer, if there's any relationship between familial factors.
Those studies are just starting. We certainly like to initiate those sorts of studies at Penn. Probably, it's been felt that about a third or more, perhaps, of all lung cancers in never smokers or minimal prior smokers may be due to secondhand smoke, and certainly that could have been a factor. One of the other things that we are starting to do, I mean, all of you are familiar with folks who smoke very heavily and never get lung cancer, so there may be certain family pedigrees, certain familial predisposition that does put individuals within specific families more at risk. So again, that's still very embryonic research, and that needs to go forward. Ideally, we'd love to identify the BRCA1 or BRCA2 gene that's been associated with breast cancer, see if there's something similar that can be identified in lung cancer. I'm virtually certain something of that sort is out there, but we have not yet figured that out, and obviously that's a major focus that needs to happen.
Thank you.
If you can go to the microphone, please.
Yes, I had lung cancer surgery in May, and after a CT scan, et cetera, et cetera. And it was because it showed up on the scan. When the surgeon went in, he saw these microscopic pieces, and he didn't remove the larger piece. And so I've been in chemo ever since, over a year now, and I'm preparing for Cyber Night. However, what I'm asking is has the test been, some CT scan been developed to see microscopic pieces? I think I heard something about that they are developing some sort of machine or something that can detect microscopic pieces.
Gotcha. So CT scans as well as MRI scans can detect lesions about 1 millimeter in size. That's really not considered microscopic. It's small, but not small in the microscopic level. There's another technology called PET imaging that I actually do a lot of research in that can show you lesions at the molecular level. And I think that has the most promise for detecting any type of malignancy that you may not see on the CAT scan. And so there's a lot of research being done. Some of those disclosures I made are actually related to trying to detect spread of lung cancer that you can't otherwise see with other imaging techniques. But very small microscopic disease you probably can't see with any imaging technique the way we currently do it, based on the physics and technology itself.
Again, I think this is going to take some sort of serum test or blood test ultimately to be able to do that. And as Dr. Torigian's pointed out, we're not there yet. We obviously have to get there. Any other questions for this session? There'll be plenty of time for additional questions during the individual sessions and certainly during lunch and later. I want to thank you again, Drew.
Sure.
Wonderful. Okay. We're going to actually have a brief break, but not yet. There'll be concurrent sessions now in each of the rooms for early stage non-small cell lung cancer. And I think most of you know what your diagnoses are, what you're concerned about. That's going to be in the Gladwin room. All of these are located on this side of the hotel, and staff right outside will be happy to assist you to find the breakout sessions. So early stage, stage 1 and 2 is the Gladwin room. Stage 3, or what we typically call locally advanced, is in the Haverford room. Wonder where they found all these names for these rooms, huh? Advanced or stage 4 or recurrent is in this room. It's the Versailles room. And then small cell will be in the Marion room. At 12:15, so we have about 2 hours, close to 2 hours for the upcoming sessions. 12:15 there'll be lunch. I'm going to introduce Dr. Nancy Gatchett, who's part of the Pennsylvania Lung Cancer Partnership, a tireless advocate for our cause. We'll speak briefly at that point. There'll also be a special lunch breakout for African Americans. This will be in the Renaissance Room. Dr. DeLisser, Brenda Bryant, and Doug Henderson from WDAS will be facilitating a session on coping with both the physical and emotional journey that comes with this diagnosis. In this room, there will be lunch with the doctor, if you'd like. Very informal. There'll be tables reserved for this, so just look for the table with the doctor's name. And during lunch as well, there'll be a live web chat that'll take place on oncolink.org/webchat. You can log on. The code number for the hotel wireless is listed on each of the tables on a little card. You can send in questions. So you can ask doctors live. You can ask them through the internet. And there to answer questions include Chanita Hughes-Halbert, who you met earlier, conference co-chair, who talk about sociocultural and psychological aspects of cancer and cancer disparity. Anil Vachani from Pulmonary Department, Interventional Pulmonology. One of our newest recruits, Charu Agrawal from Medical Oncology. Another very new recruit, Charles Simone from Radiation Oncology. Tane Petchett from Surgery. And Susan Stonehouse-Lee, one of our nurse practitioners, who will be happy to talk about managing symptoms. Lunch will conclude at 1 p.m., and then we will reconvene from all those other rooms into this room, and we'll start the hour and a half afternoon session at that point. So there is a 10-minute break. Please feel free to circulate throughout the room. All sorts of ancillary services are represented here, and they are eager to talk to any of you. Feel free to talk to us as well. Please, at the end of 10 minutes or so, go to the assigned room that is appropriate for your situation. Again, thank you all for coming.